Most of what people believe about hair loss did not come from a clinic. It came from a relative, a stylist, a comment section, or a product page that needed you to believe something in order to sell you something. August is recognized as Hair Loss Awareness Month, and the American Academy of Dermatology uses the observance to point the public toward evidence-based information and toward board-certified dermatologists. We are going to use it the same way. One note before we start. We do not diagnose. Nothing in this video replaces evaluation by a physician. What we can tell you is what the published research says and what we see across a caseload of medically complex clients. The first myth is the one we hear most, that the scalp needs to breathe. The scalp does not breathe in the respiratory sense. Hair follicles receive oxygen and nutrients through the blood supply beneath the skin. The dermal papilla at the base of the follicle holds a capillary network that feeds the rapidly dividing cells of the hair bulb. Your follicles are fed from underneath, the way roots are fed from soil rather than from the air around the leaves. You can put a cover over a garden bed. You cannot starve it by doing that. What you can do is trap heat and moisture underneath and change the conditions the roots are living in. That is the real question with any covering, not air. Conditions. So what actually matters underneath is heat, moisture accumulation, friction, pressure, hygiene, tension, adhesive exposure, wear duration, and whether the scalp can be reached for cleansing and examination. Here's the harm this myth does. A patient going through chemotherapy is told her hair will not come back if she covers her head. So she does not cover her head. She spends months exposed and self-conscious during the hardest year of her life, while the variables that genuinely affect her scalp go unaddressed. That brings us to the second myth, that wigs cause hair loss. The mechanism people are describing is real. The attribution is imprecise. Traction alopecia results from sustained tension on the follicle. The literature identifies a wide range of practices capable of producing it. Tight ponytails, high buns, braided extensions, locks, sewn-in wefts, and hair prostheses. The frontal and temporal regions are affected most often. Wigs appear alongside styles most people consider unremarkable. The determining factor is not the category of the item. It is the load placed on the follicle and how long that load is sustained. Think about a ring worn a half size too small. The ring is not the problem. Wear it every day for a year and the finger tells you it was. Same principle with a cap that has to be forced to stay on. A unit that is undersized or secured under excessive tension places continuous mechanical load on the perimeter. Now, adhesive is a separate issue entirely. The way a bandage that pulls skin on removal is a different problem from a splint that is too tight. Adhesive brings irritation, sensitization, epidermal stripping, residue buildup, and traction during improper removal. A client with adhesive dermatitis is not presenting with the same problem as a client with perimeter traction, and treating those as interchangeable leads to the wrong correction. This is also where one marketing word needs to be retired. Breathable is a descriptive term, not a clinical specification. It tells you nothing about density, nothing about how the base is sealed, nothing about wear duration, and nothing about whether the scalp can be reached and cleaned. No material is clinically appropriate by itself. A foundation is a system. It governs heat, moisture, friction, pressure, evaporation, adhesive exposure, and scalp access. Every one of those is adjustable, and everyone carries more clinical weight than the fiber the base is made from. The third myth is that shedding and hair loss are the same thing. They are not, and confusing them sends people down the wrong path for years. According to the American Academy of Dermatology, shedding between 50 and 100 hairs a day falls within the normal range. When the body sheds significantly more than that, the condition has a name: telogen effluvium. Leaves fall from a healthy tree every day. That is not the tree dying. The question is never how many came down. It is whether the branches are still producing. Excessive shedding commonly follows a stressor: childbirth, serious illness, surgery, divorce, job loss, caring for a sick family member, and it typically appears months after the event rather than during it. A new mother often notices it around 2 months postpartum, peaking near the 4th month. That delay is why so few people connect the two. They search for a cause in the present when the cause sits in the past. In many cases, the shedding resolves as the body readjusts, and fullness tends to return within 6 to 9 months. Where the stressor stays, the shedding can stay with it. Now contrast that with loss driven by follicular miniaturization, autoimmune attack, or scarring. Alopecia is broadly classified as non-scarring or scarring, and that distinction carries the prognosis. In non-scarring alopecia, the follicles are preserved and growth can resume once the cause is removed. In scarring alopecia, the follicles are irreversibly destroyed. So raw volume is a weaker signal than most people assume. Pattern, location, duration, and whether the follicle is still producing are what carry diagnostic weight. Cosmetologists study the scalp. Trichologists study the scalp. Dermatologists study it medically, and they are the ones who diagnose. Get the diagnosis before you buy the solution. The fourth myth is the one that costs people permanently. That traction alopecia always grows back. Traction alopecia has affected approximately 1/3 of women in some studied populations of African descent. Prevalence varies by population, by hairstyling practice, by age, and by how the studies were conducted. So treat that as a signal of scale rather than a fixed rate. Stage determines outcome. Early traction alopecia involves inflammation and non-scarring loss, and at that point, the follicle can often recover once tension is reduced. Sustained traction can produce longer-lasting follicular damage, and where it continues, the process may progress to scarring alopecia. This one is a crack in a windshield. Early, it is a repair. Left alone, it spreads, and then you are replacing the whole thing. The window closes, and you cannot reopen it by deciding to take it seriously later. Scarring alopecia is defined by the destruction of the follicle and its replacement with fibrous tissue. That produces permanent loss. There is nothing left to stimulate. It is also why central centrifugal cicatricial alopecia, a scarring condition that disproportionately affects women of African descent, responds poorly to treatment once it has progressed. So the question reduces to how early someone acted. The early warnings are specific, and they get ignored constantly. Tenderness or soreness after installation. Headaches caused by a style. Small bumps or pustules along the hairline. Fine, wispy hairs where dense hair used to be. A hairline that is quietly moved back. That list marks the window in which reducing tension may still preserve the follicle. To the professionals watching, we want to be direct about one thing. Pain is not proof that a style is secure. It is a warning that the mechanical load may be excessive. A style that requires a client to endure something is a style that needs adjustment. The fifth myth is that chemotherapy hair loss is always temporary. Patients are told this routinely, and for many of them, it holds. For a meaningful minority, it does not. In one 3-year prospective cohort of 61 patients with stage 1 to stage 3 breast cancer receiving adjuvant chemotherapy at a single medical center in Seoul, just under 40% met the study's criteria for permanent chemotherapy-induced alopecia at 6 months, and just over 42% at 3 years. Most of those cases involved incomplete regrowth rather than complete baldness. Taxane-based regimens carried greater risk, though the small sample makes that estimate imprecise. In that same group at 3 years, thinning was the most commonly reported problem at 75%, followed by reduced volume, hair loss, and premature graying. Participants with permanent alopecia reported worse body image scores than those without it, and the authors described that difference as clinically meaningful. We want to be careful here. That was one institution with a small sample, and the authors state plainly that the findings may not generalize. What we are pointing to is the direction of the signal, not the precision of the number, and other published work supports that direction. A field comes back after a fire. Sometimes it comes back thinner than it was, and that's not the field failing. It is what fire does to some ground. We raise this for one reason. Survivors who were promised full regrowth and did not get it often conclude they did something wrong, or that they simply need to wait longer. They wait years. They deserve to know that persistent post-treatment alopecia is documented in the literature, that it is not a personal failure, and that long-term hair replacement options are available. Which brings us to the sixth myth. That hair loss is a vanity concern. Alopecia arises from a wide range of causes. hereditary pattern hair loss, autoimmune disease, cytotoxic and endocrine therapy, physiologic and psychological stressors, endocrine and nutritional factors, inflammatory scarring conditions. Not one of those is a styling preference. The psychological burden is documented rather than anecdotal. A systematic review and meta-analysis covering children and adults with alopecia areata found higher likelihood of anxiety and depression diagnoses and impaired quality of life. And a UK study of 596 patients using validated instruments concluded that the psychosocial impact was severe and that it tracked more closely with patients' illness perceptions and experience of stigma than with the clinical severity of the loss itself. Sit with that finding. How much hair a person has lost predicts their distress less reliably than how they believe the world sees them for having lost it, which means the dismissal is not neutral. It is part of the injury. So here is what we would ask you to take from this video. Follicles are fed by blood, not air. Tension damages follicles regardless of what creates it, and adhesive damage is a separate problem requiring a separate correction. Shedding and loss are different conditions with different outcomes. Traction alopecia has a window and it closes. Chemotherapy alopecia is not always temporary, and no one needs to justify caring about any of it. Tenderness, pustules, and a receding hairline are reasons for prompt evaluation, not cosmetic concerns. One last point, because we would rather you hear it from us. A custom cranial prosthesis is a medically prescribed hair replacement solution built to an individual's measurements, diagnosis, scalp condition, attachment plan, and wear schedule. It is not federally regulated as a medical device. The FDA's published policy on wigs states the agency does not assert jurisdiction over them. The term carries clinical and reimbursement meaning, not a regulatory guarantee, which is exactly why construction specifics deserve scrutiny. The full framework is documented in the Hair and Wig Science series, and the clinical training sits inside the Hairline Illusions Arts, Science, and Technology Institute, a Florida state licensed institution. If you found this useful, take a second and like the video, follow the channel, and share it with someone who needs it. It genuinely helps this work reach the people looking for it. We are building a public record of clinical standards for hair replacement in the open. Every share puts accurate information in front of someone who has been handed folklore instead. Thank you for watching.